Should we start, madam?
No, let me just share the screen only then.
Okay.
Mr. Shriman,
Yes, madam.
what to share screen? It is the option I said. No, my desktop is showing no.
Madam, sorry, madam. I'll share the screen so you PPTs,
Okay.
madam.
You will share the PPT?
Yes, madam.
Module 1?
Yes, ma'am. I'll do.
Okay. Thank you so much. But make me a co-host so I can run my slides myself.
I'm already your co-host, ma'am.
Okay. So can you share the slides so I can see that it is working? But can you guess what has gone wrong, because why it is not coming? Yes,
My screen
ma'am.
is visible.
हाँ, मुझे दो वो दिखाने हैं, एक तो WHO सेवर किट वाला वीडियो और एक नॉर्म्स एंड स्टिग्मा,
ये फुल
दो
स्क्रीन है
वीडियोस
ना
दिखाने
आपका?
हैं.
Slides are not moving.
Madam, if you say next, then I'll change the slides, madam.
Can't I change myself?
No, madam. No, madam. I'll.
Shriman, give the access to ma'am, no?
Yes.
Okay.
Thank you so much. Savita, you are doing the second program or third program?
Second one, madam.
Huh?
Second one.
Second one.
Third one is by Ruchika and fourth one Dr. Aarti. Third by Ruchika, Dr. Ruchika, and fourth by Dr. Aarti.
Dr. Aarti has done 4 programs.
मैम नहीं मतलब
आज का वैसे
आज
मैम
का
ये
मैडम.
पूछ रही है कि आपने कितनी ट्रेनिंग करवाई है.
अच्छा.
नमस्कार मैम.
नमस्कार आरती.
नमस्ते आरती मैम.
Bye.
नमस्कार डॉक्टर संगीता.
I am not still able to move my slides myself.
डॉक्टर मीनल मैम वो भी हो जाता है, आप बोल दीजिएगा इनसे नेक्स्ट कई
नहीं, वो
वेबिनार्स
ठीक है.
में बोल.
I understand, but if you can get that, it is a best thing to
Yes,
have the
ma'am.
control yourself.
Hello, ma'am.
Hello. Shikha, how are you?
Yeah, I'm fine.
Should we start, madam?
Yes, now start.
Okay. So now today's we are going to have this REC program that for not only for Agra Society but also for the Saharanpur and Roorkee Society. And to begin with, the first module will be taken by our respected Yashodhara Pradeep Madam. She is Vice President elect Foxy 2022-23, Professor and Head of Gynae, Dr. RML Institute of Medical Science, Lucknow.
Yes.
And Senior Professor KGMU. Professor.
Madam, I gave you an access, madam. Can you please approve?
No, my slides are not moving.
Madam, I gave an approval. You just have to accept, madam. Your slides will not move, madam, because I'm sharing my screen, right?
Okay, what do you say?
I gave you an access, madam. You just have to accept my request.
How to accept? Click on it.
Yes, madam. And you just click on the slides, madam. Next slide. Yes.
Yes. Thank you.
Welcome,
Thank
ma'am.
you.
Even do the same for me also, okay? Then
Okay,
then
madam.
I have to start and you just read. So, first module will be taken by Dr. Yashodhara Pradeep, and she is the Vice President elect Foxy 2022-23, Professor and Head of Gynae, Dr. RML Institute of Medical Sciences, Lucknow, Senior Professor KGMU, Professor ELMCH, Lucknow, Chief Editor JMH, IMS, teaching experience more than 35 years, President Lucknow of Gynae Society, President Lucknow Menopause Society, Vice President IMS 2018, Chairperson Family Welfare Committee Foxy, Best Teacher Award KGMU 2015, Best Paper Award Foxy 2012, Chairperson CIMP Urogynae Committee, received various awards and honors from Foxy PSI, founder, member of ISOCOP, PCOS, LMS, ISPAT, various positioning in Foxy, IMS, IPMB, LOGS, ISOPAP, PSI and PFI, etc. Publication in international and national journal to 25 and chapter 7 and modules 10. It's over to you, madam. You just.
Thank you, Savita, for your kind introduction. So good afternoon, everyone. And my best wishes to Agra Society. Savita is very, very active person. Aarti is there. And to my all co-trainers, and especially the Saharanpur Society and the Roorkee Society who have joined here. So to the present secretary who have been collaborating with the Agra Society and all the members of the Agra Society and the Roorkee and Saharanpur Society. So it's a very, very important program, the respectful abortion care, because we know that abortion is legalized in India for a long time. Probably it is the first or second country who has legalized the abortions. But we are not still able to give the quality services. That's where the obstruction is there. Still, there is a unsafe abortion is the third cause of mortality, of maternal mortality. So this is very sad. In fact, last time we were just talking about somewhere the cases of the near miss cases, and it was a very bad. Still, we are seeing the bowel is being taken out through the vagina. So it's a very painful to see that in MTP you see such kind of the situations in which the people have to go to the colostomy and the laparotomy and then hysterectomy and whatnot. And still they are admitted in the hospital sometimes 3 months, and so many blood and so many things. So very bad situation. So this respectful abortion care has come not only to say that what are the methods and other things, other co-trainers are going to talk about it. I'm just going to talk about what are the amendments government has done to make it more safe. So coming to next, please. It's not, yes. So objective of the module is, go to the first slide, second slide. Yeah. What are the, please, next. Yeah. What are the new laws and what are the changes in the rules? Next, please. Next, please. Yes. So unsafe abortions, I have already said it is, no, the third slide. This is the slide. So 8% of maternal mortality deaths are due to the abortion. It is third leading cause. Next, please. Next, please. So when you consider the abortion is safe, when it is done by the appropriate method and done by the trained person, only then it is safe, the green. If one is there, then it is less safe. If both the things are not there, then it is not safe at all. Next, please. So Medical Termination Amendment Act 2022 is for the safe and comprehensive care mandated by the law. Next, please. So what are the salient features? Previous Act said that requirement of option of one provider for MTP up to 12 weeks and requirement of the option of 2 providers up to 12 to 20 weeks. But what the new law says? The new law says there is only one practitioner is allowed by the one practitioner is allowed for that up to 20 weeks. Only 20 to 24 weeks you are allowed to. 2 providers are required. So what is the potential outcome of this change in the law? That we have to improve our facilities. We have to Just let me see. We have to improve our public sector facilities, PSCs especially, which can have the facilities to provide the abortion up to 20 weeks. Next, please. Next, please. Next. Next, please. Shikha is coming full screen. I want next. Who is the co-host? I'm not able to see my screen. I'm Mr. Shriman. Mr. Shriman. Shikha, you have to Mr. Shriman. Mr. Shriman, are you listening? Are you there? Mr. Shriman?
Madam, should I try my?
उनका इंटरनेट स्लो हो गया होगा इसलिए बंद हो गया.
किसका इंटरनेट?
श्रीमान का. I think.
Because my is not, the screen mein I could not see my slides, so I can just speak it out.
Madam, you can share your one if you are having a.
I said now my laptop has been updated. It doesn't show my desktop. I have to ask somebody to how to show it. It was all gone. It crashed basically my laptop week ago, and then my daughter came, and then I could not do anything.
श्रीमान को मैं कॉल करती हूँ मैडम, मैं देखती हूँ what has happened to him. रुचिका, can you share मैडम का share कर दो?
मैं डाउनलोड कर रही हूँ मैम in the meantime.
हाँ.
आज वो
disappear.
He has disappeared.
मेरे में भी व्यू ओनली आ रहा है डाउनलोड का स्लाइड शो.
Yes, next please. Next please. Yes. So the previous act said that MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. But the 2021 amendment says enhance the upper gestational age up to 24 weeks. And it has further enhanced birth defects not compatible with life on medical board consensus. So you require medical board consensus after 24 weeks. So potential outcome is that we have given the increased access for the vulnerable women, which I am going to just talk about next work. That legal, who are the vulnerable group? Next, please. Next, please.
I've changed the slide, madam.
Okay. So Act had provision of termination of such pregnancies only up to 20 weeks. Upper gestational age does not apply in case of pregnancies substantial fetal abnormalities. So for any substantial, like who is putting this lines here? Please stop.
Someone is.
So if there is a substantial, like we have gone through the NN-CAFD, which has come to us at 28 or 32 weeks, we could not terminate. But now here you can terminate at any time without any problem. But you have to go to the medical board. That's the whole problem. Next, please. So the previous act says the condition of failure of contraceptive was applicable only for the married woman. Now it is extended to the woman or to her partner. Anybody who had a contraceptive failure, either a woman or the partner, will be given the choice of termination of pregnancy without any problem. You have to terminate the pregnancy. You don't have to ask questions. Why this has happened? Why not this has happened? So this has done to increase access to safe and legal abortion for any woman, irrespectful to the marriage age, or especially with the upcoming changes in the legal age of the marriage, an important advancement for increasing access to the safe abortion. Next, please. The Medical Termination of Pregnancy Regulation 2003 mentioned that information should not be disclosed except under authority of the law. But the new law says that name and other participant of the woman who has been come for the termination shall not be revealed except to the authorized by the law. Except the person who has been authorized by law, you have to reveal the information. Otherwise, you are not supposed to reveal the information of the person who is coming for the MTP. Next, please. So law is salient. MTP Amendment Act 2021 is still on the privatized confidentiality and safety. So it is name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being in force. So any person who is in the time being in force, to say this is a salient feature of the MTP Amendment Act, that you don't have to disclose that this woman had gone MTP unless a person who is authorized by law has come and asked you the records. Only then you have to mention the records, or you have to reveal the records. So the ground of the failure of contraceptive has been extended to the woman and her partner, irrespective of the whether it is married or unmarried. Next, please. So under the amendment of 2021, they define the special or vulnerable category of the women which are eligible for extended gestational age up to 24 weeks. Norms for the registered medical practitioners who can do it, and powers and functions of the medical boards has also been described under the amendment 2021. Next, please. So under the rules of MTP Amendment 2021, the special category of the women, the survivors of the sexual assault, they can have MTP without any problem up to 24 weeks. Women with pregnancy in humanitarian ground setting, disaster, emergency situation declared by the government, like the lockdown, many people could not come. So in that case, also it has been extended up to 24 weeks. Changes of marital status during the ongoing pregnancy. Maybe the person has got widowed or something like that, and then the person can come and see the things. Can have the MTP up to 24 weeks. Mentally ill or women, including the mental retardation. Women with the physical disabilities, major disability as per criteria under the Disability Act, can also have the abortion up to 24 weeks. Any minor can also go through the abortion up to 24 weeks. The fetal malformation, as I have already said, that it is extended beyond any gestational age without any problem, depending upon the substantial abnormality of the fetus. Yes, please, next. So now you understand what are the vulnerable category of the women who can have the abortion up to 24 weeks. So the norms, what are the norms of the RMPs? RMP is defined as the old act as MBBS or more with any. So who is the RMP? Because in the our law, in the MTP Act, it has been said that registered medical practitioner is an MBBS with who has assisted 25 cases of the MTP, of which at least 5 done independently, or the medical practitioner who has completed 6 months of the house surgery in the obstetrics and gynecology department. The medical practitioner who holds a postgraduate degree or diploma in the obstetrics and gynecology, or the medical practitioner who has experience of at least 1 year in the practice of OBGYN. So up to 20 weeks, only 1 RMP is required. Up to 24 weeks, opinion of 2 RMPs is required. Beyond 24 weeks, the opinion of medical board is required. Next, please. Next, please.
Next slide.
I've changed the slide, madam.
No, it is not changed. It's the same slide. Because here the option is not coming. So the norms for the RMP whose opinion is required for termination at different gestational age, they have also defined which RMP can do up to which gestational age the abortion. So till 9 weeks, all 5 can do it. So, but the number 1 is experience of and training of the RMP is experience at any hospital, 3 months of the practice OBGYN, or has independently performed 10 cases MTP by medical method of abortion, or under supervision of any registered medical practitioner out of any 5 category, or a training institute approved by the purpose of the government. So only 1 is required opinion, and this person could be only who has done 10 cases of the MTP by medical method of termination, and or has got a training under the any institute which is under the government, but it is applicable only up to 9 weeks. I have already defined the second time that who is a medical practitioner who has done 25 cases of the MTP, of which at least 5 has been done independently, or she has done a postgraduate training, or she has done a 6 months house training, house job in the department of OBGYN, or she has worked for the 1 year with obstetrics gynecology hospital or in the government institute. Next, please. And only 1 RMP is required till 9 weeks. Next, please. Because up to 9 weeks, you require only medical method of abortion. Till 12 weeks, again, you require only 1 RMP. This RMP could be a practitioner who assisted RMP performance of 25 cases of MTP, which at least have 5 been done independently. Now you see the first one which we had for the 9 weeks has gone, who has done only 10 cases and 5 under biomedical method of abortion. So that person cannot do the abortion till 12 weeks. Only these 4 category can do, who has done 25 cases of MTP, of which at least 5 has been done in the independently, or a practitioner who has done a postgraduate diploma or degree in OBGYN, or has done 6 months of OBGYN house surgery, or 1 year in practice of OBGYN. Only 4 categories are left who can do the abortion up to 12 weeks, and is opinion of only 1 is required. Next, please. So beyond 12 weeks, you can see we started with the 5 RMPs, but now 1 and 2 cannot do it. Either it has to be a person who has done post-graduation, or who has done 6 months of the residency, or who has done 1 year job in any hospital who is in the department of OBGYN. Because there are many multi-specialty hospitals in which the department of OBGYN is there. If anybody has worked in that department, she is eligible to do the abortion MTP beyond 12 weeks, and still the opinion of only RMP is required. So the category has been fixed for 9 weeks, for 12 weeks, and beyond 12 weeks. Next, please. So this was up to a previous one, the 3 categories up to 20 weeks, 12 to 20 weeks. Now we are going 20 to 24 weeks. This is for the only vulnerable group of the women, which we have already described, that minor disability, the mental retardation, the disaster state, lockdowns, or the person has changed, widowed, or the divorced. So all these rape survivor, all these people are the vulnerable group who can have the MTP till 24 weeks. But here only all 3 categories again, but the opinion of 2 RMPs are required. that anybody who has having a postgraduate degree in OBGYN or who is having a house surgeon for 6 months in OBGYN or has done the practice for 1 year in Department of OBGYN in any hospital. Next, please. But you require 2. This all has been done because at PSC, you do not have more than 1 practitioner. So up to 20 weeks, they said that it can be done at any primary health center or any center where only 1 doctor is there. They can do up to 20 weeks, but that doctor of which kind? That who has done the previous, I said, either the MS or diploma in OBGYN or has done 6 months house job, or she has already done 1 year or service in the Department of OBGYN in any hospital. So if the pregnancy is beyond 24 weeks, and this is, we have said that this is an option only for those who have got a substantial fetal abnormalities. So person has to go to the medical board. The opinion of medical board is required. And here only 2 categories been left, only the postgraduate or the person who has done 1 year job, 6 months house surgeon who has done a 6 months house surgery job in the Department of OBGYN cannot do the abortion up beyond 24 weeks. Only these 2 categories of the registered medical practitioners can do it, and opinion of the medical board is required. Next, please. Next, please. Yes. So what are the composition of the medical board? There has to be a gynecologist, there has to be pediatrician, there has to be radiologist and sonologist. And you can have any more number of the people. If you know that this person requires the opinion of more people, you can add in your medical board the more people. Next, please. So what are the powers of the medical board? The powers of the medical board is they can allow or they can deny the termination of pregnancy beyond 24 weeks of the period of gestation, depending upon the reports which you have sent it to the medical board. After consideration and ensuring that procedure would be safe for the woman and the fetus has got a substantial risk of incompatibility with the life. So 2 things medical board has to see, that it is safe for the mother and it is also the fetus is having the substantial fetal abnormalities for the incompatibility with the life. And you can co-opt other specialties. As I said, you need, sometimes you need a pediatric nephrologist, pediatric cardiologist. You can have all those into your medical board. And the FOXY is also with the ministry guidance and WHO support as a part of the RAC training can operationally and host the medical board information on the website. So whatever the information is coming from the government, it will be displayed on the FOXY website. Next, please. So what are the functions? Powers, we have already said what is the medical board composition, what are the powers and what are the functions. To examine the woman and her reports, they would approach for the medical termination of pregnancy, provide the opinion of the medical board with regard on the form D with regard to the termination of pregnancy or rejection of the request termination within 3 days. There is a time period. So medical board has to respond within 3 days on the form D, whether they allow or they deny the permission. And to ensure that the termination procedure has to be done within 5 days of the receipt of the reports. So within 1 week, the procedure has to be done. Within 3 days, the medical board has to give the report. And within 5 days, the procedure has to be done. And again, remember that FOXY is going to have all these information, the medical boards, which every state has to form in their districts. Already the medical boards are there. So they can have the medical boards, or those medical boards can be given those powers. Next, please. So this is the registration and pre-test, post-test and feedback is required for all the participants. And when you finish all modules, all 4 modules, the certificate will be awarded to the participant on attending the training and submission of the registration, pre-test and post-test. Next, please. So this is a Samarth Bharat, Sampurna Bharat. If there are any questions, I'm there to answer. So in the chat box, is there any answer, any questions?
No question is there.
No question is there.
You have
Okay.
explained everything in detail, so everybody is
Thank you
clear
so
about
much.
it.
So the whosoever has shared my screen, they can stop the share screening, and the next participant, next trainer can participate and can share their screen.
Thank you so much, madam.
you so
Thank you
much,
so
Savita.
much. Yes, you have explained
Yeah.
everything in detail, so everybody has
Yeah, I'm
clear
so happy to
concept.
see Ruchika and Shikha and everybody is there.
Very nice.
And Subi.
Thank you, madam. Thank you so much.
And permit me to leave also. Thank you so much.
Thank you, madam.
Thank you, ma'am.
Okay.
You're most welcome. The 64 participants are there.
Yes, ma'am.
There's a good number of the people who have joined from the roll
But I was expecting more than 100. I don't know why. Only 64
This
are there.
always happens. People forget actually, basically. People forget after registering.
Yes,
This
ma'am.
always happens. So nothing, 64 is a good number.
Thank you,
It's
madam.
going to end in the April, this RAC meeting, unless it gets some.
Allow me to share the screen, please. Can I share the screen?
We can have one photograph before I leave of the whole
Yeah.
participants.
Yeah,
Yes.
ma'am. Yeah, ma'am. Yeah, ma'am. We will
Yes.
take.
Yes, madam, we can, ma'am.
Yeah, the whole group, all participants can open their chat or their videos, and we can have one photograph.
Yes.
Yes. Please open your this thing, video, all of you, so we can have one photograph. Thank you so much. It's so good to see everybody.
It's looking nice.
Ma'am, have you taken, ma'am?
Should I take?
No, I am taking one. Anybody else also please take. Dr. Sangeeta, you please also take.
Okay.
Probably it has come to me.
Yes, ma'am.
I have taken.
Okay, thank you, madam. Thank you so much.
Okay. So we can go to the same view. One question is that do the rape victims need to prove that rape happened before MTP is done? No. There's one question by Dr. Alpana Vashne. The answer to this question is no. Capital no.
Only one guardian is sufficient to do the MTP. Consent of one guardian, or both guardians is necessary?
No. It is only one guardian is enough. Maybe the boyfriend, but he has to be above 18.
Okay.
So anybody who can be guardian, it is not at all necessary that the parent should be there. Even the boyfriend can also be there, but only he has to be above 18. And if the girl is minor, you have to report to the POCSO. These are the only two things. Yes.
Thank you, ma'am.
Madam, it is not full screen, madam.
Okay, because I don't know why this.
Savita, madam, it's not full screen, ma'am.
Yes, I am trying to do that now because.
मैम नीचे से कर दीजिए जहाँ 130% लिख रहा है उसके बगल में.
हाँ,
ऊपर
वहीं
से
पे
नहीं
कर
होगा.
रही। हाँ। हो गया, बट फिर मुझे पूरा दिखेगा नहीं यार, ये सही नहीं है.
नहीं
ये
हुआ
तरीका
मैम.
ना- हाँ, ये सारी तरीका ना सही नहीं है. मैं स्टॉप शेयर करती हूँ, पहले दोबारा करती हूँ. इधर कब दिखता है ना, वो नहीं दिख रहा, पता नहीं क्यों.
Yes. Scheme.
दिख रहा है? आर यू एबल टू सी माई स्क्रीन?
हाँ लेकिन मैम फुल स्लाइड्स नहीं है. डाउनलोड नहीं है.
नहीं यार, मैं नहीं डाउनलोड लोडेड ही है.
मैडम ये व्यू बटन पे क्लिक करिए मैडम, ऊपर जो फाइल
हाँ,
एडिट
ऊपर।
दिख रहा है ना,
कहाँ पर?
ऊपर जो
हाँ।
फाइल एडिट
शेयर के बगल में.
शेयर के बगल में.
तो ये फाइल एडिट यहाँ बता रहा है. स्लाइड शो यहाँ पे ऊपर आ रहा है ना, राइट हैंड पे.
शेयर पे आ रहा है मेरा तो. स्लाइड शो, हाँ ये आ रहा है इसके. अच्छा यहाँ पर, ओके. नो नो, इट इज नॉट. स्लाइड शो है ना ये?
हाँ वो क्लिक करिए मैडम.
हाँ हो गया ना? आ गया?
Not yet मैडम, blank screen दिखाई दे रहा.
आ गया ना? Now is
हाँ,
it
हो
Yes,
गया
ma'am.
हो गया हो गया
हाँ,
Yes.
ठीक है.
So, this I am going to tell about the safe abortion methods and what the technology and what we have to do this in this module. It consists of existing guidelines, pre-abortion assessment, what we have to do before we are going to do the procedures, and what are the medical methods and what are the surgical methods. This module contains all these things. What were the WHO global guidelines on safe abortion? These started from 2012 and so many guidelines are changing and they are coming to us by the WHO. Every year or 2 years, the guidelines are changing and we have to update our knowledge about those guidelines which are being given by WHO and by the government of India. And the WHO national publication on safe abortion started at 12 and till 2019 so many guidelines have been there. To start with, in 2012 it was about the safe abortion, technology and policy guidelines. In 2014 clinical practice handbook was there, then health worker role in providing safe abortion was there. In 2015 guidelines, in 2018 medical method of abortions were included and guidelines were given, and 2019 WHO consolidated guidelines on self-care intervention for health. 2021 was a historical year for safe abortion for India. In till 2021, we were not able to do the abortion of those patients who were having these malformed babies, and we have to fight the cases in the courts, and so many problems were there to such patients. So our government did the amendment in the Medical Termination Pregnancy Act, and now this law was changed in 25th March 2021 and rules changed on 24th September 21. So what are the guidelines and what are the guidelines? These have been put in the for the safety of the caring the abortion for safely. So these have 3 parts: pre-abortion care, abortion care methods, and aftercare and follow-up, which includes not only the post-abortion contraception and counseling. We have to always counsel the patient about the contraceptive methods when we are going for doing any abortion or MTP. So in pre-abortion care, we have to go for the medical history, and we have to go for any patient having any kidney problem, liver problem, taking any medicines, or any she's having anemia. So we have to take the thorough history, and we have to give proper time for the taking this history. Then we have to go for the physical examination, see the general examination as well as the local examination, and laboratory and other investigations are also required if the patient is having any history of medical disease. If patient is, you think she is having no problem with her, then these investigations are not necessary as per the guidelines. And then next one is the discussing contraceptive options. We have to always discuss the contraceptive options to the patient, but we should leave all the options for her, whatever method. If she is willing for the medical method, let her go for that. If she wants for the surgical methods, we have to allow for that also. Then what are the pre-abortion assessment and counseling? Detailed history taking, general physical and pelvic examination, lab and other investigations if required, and decision making, information on abortion procedures and counseling, that is must. And we have to assess, first of all, we have to assess the size of the uterus. It is after 4 weeks, the uterus size increases by 1 centimeter per week. At 12 weeks, it comes up to the symphysis pubis, and at 16 weeks, it between the symphysis pubis and the umbilicus. At 20 weeks, as we all know, it comes up to the umbilicus, and after 20 weeks, it increases 1 centimeter per week, and we have to see the size of gestation by doing the per abdominal or per PV examination. But some problems are there. If the patient is having uterine malformations, then it is very difficult to see the exact side of the pregnancy. If patient has multiple gestation, or there is marked uterine retroversion, or patient is very obese, then it is not possible to find out the exact size of the uterus, or there is a molar pregnancy. So these are some limitations for the to determine the uterine size on physical examination. And uterus can be smaller than what we expect. It may be because the patient is not pregnant, or she's not having the correct date, or she's having ectopic pregnancy or abdominal intrauterine pregnancy that may be spontaneous, or she may be having spontaneous or missed abortion. Or uterus may be more larger than what we expect. It may be because of inaccurate menstrual dating, multiple gestation, uterine abnormalities, and molar pregnancy. So what are the pre-abortion investigations? Routine lab test, not a prerequisite for abortion services. Mind it, it is not a prerequisite. But if we think that whether she is pregnant or not, we are not confirmed by the physical examination, then we have to go for the pregnancy test to confirm the pregnancy. Or if we are suspecting anemia on general examination, then we have to go for the hemoglobin testing for that patient, and RH testing. Although if the patient is primary, we all should go for the RS testing. Otherwise, also we think it is she's having some planning for the future pregnancy, then we should go. But in these guidelines, it is not written. And then HIV testing and counseling is also important. And by doing the local examination, we can find out if there is some sexually transmitted infections are there or not. Then other lab tests, if patient has kidney or liver problem, then we have to go for those tests also. Then what is the pre-abortion counseling? We have to ask the patient why she has come for termination of the pregnancy, what is the reason behind that. And we should also inform that if the abortion is done in the early stage, then it is safe. And we have to also inform that if you are going to terminate the pregnancy by the trained provider, it will be safer for her. And also we have to tell her about what are the various methods of abortion, and also risk and warning signs associated with the abortion methods. And we should also counsel that if she will not take any contraception after the abortion, she may again become pregnant after the 14 days of the abortion. And we have also tell her how many after days she can go for her sexual activities, and any other follow-up care is also advised. And what documents we have to maintain? We should maintain the informed written consent, and we have to also maintain our decision to accept post-abortion contraceptive. She is willing to take that any contraceptive methods. But if she is not willing for contraception method, we cannot ask her. We cannot deny her abortion. Still, we can go for the providing her the abortion methods, MTP. So, what are the clinical management of abortion? If the patient is having pregnancy less than 12 weeks, then what are the global recommendations? We can give the mifepristone and misoprostol combination, or misoprostol only, or vacuum aspiration. If it is more than 12 weeks, then what are the global recommendations are? Mifepristone and misoprostol can be given, or misoprostol only, or dilatation and evacuation. And sharp curettage is not recommended. We should not go for the sharp curettage when we are doing the MTP. And what are the GI recommendations for medical termination of the pregnancy? Up until 9 weeks, up to 7 weeks, that is 49 days, mifepristone 200 milligram oral. Then we have to wait for 24 to 48 hours, and then we have to go to misoprostol 800 microgram sublingual. If it is between 7 to 9 weeks, that is 49 days to 63 days, then again mifepristone 200 milligram oral. Then again wait for 24 to 40 hours, and then give the misoprostol 800 microgram sublingual or buccal. So what is the clinical management of abortion in first trimester? It can be a medical method, or it can be surgical method. That can be a manual vacuum aspiration or electrical vacuum aspiration. Then what is the role of mifepristone and misoprostol? That mifepristone is an anti-progestin that inhibits the action of the progesterone, and so it interferes with the continuation of the pregnancy. And this, because we give the mifepristone is followed by the misoprostol, and this misoprostol causes not only the cervical softening but also uterine contractions and helps in the expulsion of the products of conception. What are the various protocols? Day 1, mifepristone administration is given. 200 milligram mifepristone can be given orally. If patient is RS negative, we have to give the NTD at the same time of 50 microgram. And on day 3, mifepristone administration is done. And up to 7 weeks, 400 microgram misoprostol, 2 tablets of 200 microgram each. It can be given sublingual or buccal or vaginal or oral. Or if it is 7 to 9 weeks, 800 microgram sublingual, buccal or vaginal misoprostol is given. And in addition, what we have to give, because it will cause the when patient will expel the products of conception, she will feel pain. So we have to also add the analgesics in form of ibuprofen, or patient may have vomiting. So we have to add these antiemetics and also offer the contraception on the day 3. And within days 5 follow-up day, we have to confirm and ensure whether the procedure is complete or not. And also we have to offer the contraception if patient has not taken it already. What are the various routes of administration of these misoprostol? It can be given orally. Then these pills are swallowed, and it is recommended up to 7 weeks for the first trimester abortions. And side effects include diarrhea and nausea and fever and chills. Buccal, then pills are placed between the gums and the cheek and swallowed after 30 minutes. But in buccal route, patient will have more fever and chills than with the vaginal route. Sublingual, here pills are placed under the tongue and swallowed after 30 minutes. It is associated with more fever and chills, diarrhea and vomiting compared to the vaginal route. But it has the fastest onset of action and highest plasma concentration levels. And vaginal route, pills are placed in the vaginal fornices, deepest portion of the vagina, and the woman is instructed to lie down for at least 30 minutes. And it has the lowest rate of side effects, and pill fragments may be visible at the vulva. So these are the pictures which depicting the buccal and the sublingual routes of misoprostol administration. What are the WHO drug regimes dose schedule for medical abortion? What are the recommendations? If induced abortion less than 12 weeks, mifepristone 200 milligram per oral once, and misoprostol after day 1 or 2, 24 to after 24 or 48 hours, 800 microgram buccal per vaginal or sublingual. And for second regime is misoprostol only regime, in which only the misoprostol is given, and that dose is the same, 800 microgram buccal per vaginal or sublingual. And vaginal bleeding for 2 weeks is normal after medical abortion, and such bleedings may last up to the 45 days in rare cases. So we have to counsel the patient if she is having bleeding for 2 weeks, then it is a normal. It may take up to the 15 days, 14 to 15 is normal, but in some patients it may take up to the 45 days. Then what are the provision of medical method of abortion services? It, as madam has already said, that it should be at the primary care level, and with referral system in place for all required higher level care. And additional service may need to be provided to individuals who are coming for the medical abortion, like counseling and testing for STDs, like HIV or a VDRL test. And we also ask her, don't take these pills again and again. It can be harmful for her health. So we have to support abuse. Support service should be there. And psychological or social services should be there. Sometimes patient is came because of maybe a victim of rape or widow. So we have to give her the psychological support also. And other specialist health or medical services are also provided. And if patient is anemic, we have to give her iron tablets. And if patient is having pain, then painkillers are also provided, and emotional support is always provided to these patients. What is the follow-up care? Routine follow-up is not necessary following an uncomplicated medical abortion using Dimitrifestron and Misoprostol. But only if you have used the Misoprostol regime, then we have to follow these patients to see whether this abortion is complete or not. If you are doing follow-up visit, it has to be done after 7 to 14 days, and we have to see whether the procedure is complete or not. And we have also counsel her about the contraceptive methods, and we should give the emotional support or address if having any medical concern, like if she is suffering from anemia, we have to also treat the same at the same time. Then what is the follow-up care? When patients come to you in the follow-up, we have to see her recovery and ask for any sign or symptoms of the ongoing pregnancy. If she's having still nausea, vomiting, and we have to check whether pregnancy is continuing or not. And or we have to also check the medical records and documents with her, and ask about any symptoms experienced since the procedure. If she's having acute pain like that or any excessive bleeding, and perform a focused physical examination for any complaints, and assess women's fertility goals and need for contraceptive services if not provided earlier. What is the medical method of abortion summary? What to do when patient come to you on the day first? Physical and pelvic examination, confirm eligibility, and tablet Dimitrifestron 200 milligram orally after offer NTD 50 microgram to RH negative women. Tell the women to return for Misoprostol administration after 2 days. Always give the address and the contact number of the facility to the patient when we are giving the medical method of abortion, so that she can contact if she is having any emergency in that time, she can contact the facility. And also we have to provide her the medical method abortion card. So to record her experience of any side effects, she can mention there. It has been seen that 3% of women may expel completely with Dimitrifestron alone. Second visit, we have to call her after the day 3. And day 3, we have to give 400 microgram of Misoprostol. Sublingually, can be given buccally, vaginally, or oral. Then observe her for 4 hours at the facility, and also give the analgesics like ibuprofen 400 milligram, and also ask her to also discuss about the contraceptive options like condoms, hormonal methods, oral or injectables. And tell the patient that mean period of bleeding may be 8 to 13 days, and possible side effects, as we have already mentioned, can be nausea, vomiting, diarrhea, headache, fever, dizziness. And if she's asked her to report if she's having excessive bleeding or pain, abdomen or fever, and report if there is no bleeding 24 hours after Misoprostol, considering giving additional dose of Misoprostol. And it has been seen that 75% women abort within 4 to 6 hours after Misoprostol administration. And what to do in third visit? When you call her at the day 15, we have to go for the pelvic examination to ensure the completion of the abortion, and also we have to counsel about the contraception methods, hormonal methods, condom. We can also insert the IUCD at the same time, and sterilization after 1 menstrual cycle. And tell the women that about immediate return to fertility, report back if there are no periods within 6 weeks of completion of the abortion processes. But if patient is having acute pain in the abdomen, then we have to go for the USG examination to exclude the ectopic pregnancy. What are the side effects and complications? Pain. Yes, pain is patient may feel pain when she expel the products of conception. So be respectful, non-judgmental communication should be there. We should always give this verbal support to the patient, do the adequate counseling, support person. Ibuprofen 400 milligram has to be given. If patient is persistent pain with failure to respond to these drugs for several hours, warrant evaluation for other causes such as ectopic pregnancy, infection, or incomplete abortion. We have to reassure the patient about the nausea and vomiting and diarrhea, because these are the self-limiting problems. And patient is having infection which has been confirmed by physical examination, then we have to start the antibiotics. Action for failure. If the or it is an incomplete result of medical method of abortion. If it is failed, offer a vacuum aspiration, or we can repeat the medical method of abortion. If it is incomplete, observe unless heavy bleeding is there, or repeat misoprostol, or offer surgical method of evacuation. If patient is having bleeding resolved and uterus size comes to the normal, it means abortion is complete. If patient is still having heavy bleeding, then we have to go for the evacuation, and repeat misoprostol is also one of the alternative. Then, how to manage a patient is coming for excessive bleeding PB. If patient is having bleeding more than her menstrual cycle and soaking 2 pads in 1 hour or 2, then it means the bleeding is excessive. And if bleeding decreases over time, then we have to go for the routine care, keep a watch on her vitals and bleeding PV, and she can go home. If bleeding is not decreasing over the time, it means then we have to watch her vital signs, do the PV examination. POCs, if the POC is in the cervical canal, then we have to go for the digital evacuation. And then patient become stable and bleeding reduces. Then observe and monitor and vital signs and bleeding PV for 1 more hour. If still bleeding continues, then we have to go for the ultrasound examination of this patient, see whether any minimal residual bites are there, or POCs and residual bites, and woman is stable, nothing to do. Stable, then we have to go this misoprostol for 600 milligram or to 400 milligram. Woman not stable, then go for the evacuation, and patient continuing of the patient, then surgical method of evacuation has to be done. Then how to do the recording and reporting for medical method of abortion. This also comes under the MTP Act, so documentation is very much important even for those patients who are going for the medical method of abortion. So we have to take the consent in the Form C, and we have to also write down your opinion on Form 1, why you are giving her medical method of abortion. Form 2 has to be sent every monthly to the CMO office for district authorities. Form 3 is admission register for case records. So documentation is very important. Even if you are going for medical method of abortion, it is must to document all these things. What are the surgical methods? It can be manual vacuum aspiration, or it can be electrical vacuum aspiration. So vacuum aspiration is recommended technique of surgical abortion for pregnancies up to 12 weeks. And WHO recommends manual vacuum aspiration as the safest method, and this procedure should not be routinely completed by sharp curettas. What is the procedure? As most, I think most of us are using this vacuum aspiration, manual vacuum aspiration. This is a syringe, handheld aspirator used to generate the vacuum, and it is attached to 4 to 12 millimeter of cannulas according to the size of the pregnancy. And this cannula can be used in multiple settings, including those without electricity. And EPAS or easy grip cannula size corresponds with the week of gestation. That is 8 millimeter cannula means 8 weeks gestation, and 10 millimeter for 10 weeks. And electric vacuum aspiration with electric pump used to generate vacuum, and it can accumulate same cannulas which we are using for the manual vacuum aspiration. Cervical ripening, it may be considered for women with the pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate, especially if the patient is preemie. And recommended method for cervical preparations are either we can give oral mifepristone 200 milligram 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered vaginally 3 hours prior to the procedure, or laminaria placed intracervically 6 to 24 hours prior to the procedure. If the size is quite big, then it is better to put the laminaria. What is the pain management? It is very important to look for the pain management of the patient. And this pain management not only reduces the pain, it also reduces the anxiety and makes the woman more comfortable. And there are two components of the pain management. It can be non-pharmacological or can be pharmacological. In non-pharmacological, we provide the psychological support to the patient, explain each step of the woman in advance so patient comes in confidence, and we perform the procedure gently and smoothly, and encourage the women to relax and breathe deeply. What are the pharmacological pain management? If patient is very much anxious, then anxiolytic like diazepam can be given. It can be given only 10 milligram dose 1 hour prior to the procedure, or general anesthesia can be given by giving 2 to 5 milligram IV 20 minutes prior to the procedure, and duration of effect is 4 to 6 hours. And what are the side effects of the diazepam? Patient may have disorientation or dizziness. For cervical dilatation, we can use the local anesthesia, lignocaine, or we can give the analgesics in the form of ibuprofen. Lignocaine can be injected 10 ml of 1% lignocaine can be injected in it for disease, and it effect lasts for 60 to 90 minutes. And analgesics, this 400 to 800 milligram of the ibuprofen can be given 1 hour prior to the procedure, and effect lasts for the 4 to 6 hours. And if patient is in uterine cramping, then analgesics that like ibuprofen can be given 1 hour prior to the procedure. It's also duration effect is 4 to 6 hours, but the side effects, if we are giving the ibuprofen, patient may have gastritis. And when we are giving the lignocaine, if it by chance goes into the blood vessels, then patient may have dizziness or the seizure. So we have to be very cautious when giving the paracervical block by the lignocaine. What are the steps? First, we have to close the valve button, then create a vacuum, ensure pain control. Step medication is given at the appropriate time. Ask the woman to empty the bladder, then perform the antiseptic preparations, administer paracervical block, dilate the cervix, and insert the cannula. Then release the vacuum, and then rotate, withdraw the cannula 1 to 2 centimeters from the fundus and rotate the cannula, and do the smooth, gentle evacuation. What are the signs that uterus is empty? Red or pink foam without the tissue passing through the cannula. It means the grateful sensations are there over the surface of the uterus, or cervix gripping over the cannula, or uterus contracting around the cannula, or there is increased uterine cramping. Then what is the step 8? Always inspect the tissue whether it is corresponding to the size of gestation what we have seen before doing the starting the procedure. Then proceed with contraception if patient is has given the consent, like IUCD insertion, or patient is waiting for the sterilization, then we can go for the sterilization at the same time. Or when how to do the sterilization of the instruments. These instruments to be soaked in chlorine solution 0.5%. Not only assist the disinfection, but also remove the tissue and body fluids from the instruments. Then what is the post-procedure care? Monitor her for any complications, just like and provide management as needed. If everything is okay, she is stable and meets the criteria of the discharge, she can leave the facility. We have also ensured that the woman has all necessary information and a medication prior to leaving the facility. And we have to document. Yes, documentation is very important. Document all outcomes of the treatment, including any adverse events in the facility, and register and client's record. If patient had any side effect of any drug, we have to mention on her card. And infection and bleeding or ongoing pregnancy, and we have to manage all these complications. And second thing is we have to always give the provision of contraceptive information and offer contraceptive counseling and methods, and also assessment of any other sexual and reproductive health needs that may require additional care. Follow-up, no routine follow-up unless meso alone regime is used. It is a new recommendation. In summary, India has made historic progress in improving access to safe abortion. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context to the amendment law. Along with safety, we also need to focus on respectful abortion services. Yes, it is very important to do the respectful abortion. Every client, public or private, an opportunity to inform, educate, and equip with proper information on contraception and counseling is must. So it is very important to do the registration and pre-test and post-test and feedback. Then all attendee will get the certificate of participation. So let us make it safe and respectful. Thank you all for giving me this opportunity. If any questions, please, questions are there.
Thank
I will
you,
share.
ma'am. बहुत अच्छा पढ़ाया आपने.
Thank you, Ruchika. Thank you so much.
Excellent, Sarita. It was lovely teaching.
Thank you, madam. Have you joined, madam? Thank you so
Yeah.
much, madam.
Yes. Ma'am, मैं करूँ अपना?
Now Dr. Ruchika is starting her module 3. She is an associate professor at Asset Medical College, Agra, and she was secretary IMS with me. And now she is Suffolk journal editor also. So it's over to you, Ruchika.
Thank you, ma'am. So अभी हम डिस्कस करेंगे सेफ अबॉर्शन, वैल्यूज, एविडेंस, राइट्स, रेस्पेक्ट से सेवर कहा गया है, रेस्पेक्टफुल अबॉर्शन केयर. अभी तक सिर्फ रेस्पेक्टफुल मैटरनिटी केयर डिस्कस की जा रही थी, लेकिन फॉक्सी इज द फर्स्ट अमंग ऑल द सोसाइटीज जिसने की रेस्पेक्टफुल अबॉर्शन केयर इनिशिएट किया है विद WHO. ये क्यों नहीं हो रहा? यस. So at the end, we will know what is respectful abortion care. We will discuss what are the norms and stigma, how they affect, and WHO saver resources. Now we know that momentum create हो चुका है, law change हो गई है 1970s से. Foxy has provided the largest provider base for abortion care. Because of COVID, now online trainings भी possible हैं. और जैसे कि सविता मैम ने अभी मेडिकल मेथड्स ऑफ अबॉर्शन बताया, जो कि बहुत ज्यादा जिसका अपटेक इंक्रीज हो चुका है, और मेडिकल मेथड ऑफ अबॉर्शन अर्ली प्रेगनेंसीज में ही हो जाता है, तो इसलिए PNDT का भी कोई इन्वॉल्वमेंट नहीं होता, क्योंकि सेक्स सिलेक्शन फर्स्ट ट्राइमेस्टर के बाद ही होता है. सो पेशेंट की सेफ्टी, रेस्पेक्ट एंड क्वालिटी, इट मैटर्स मोर देन एवर, एंड वी हैव ए रोल टू प्ले. So basically, what is respectful abortion care? It is adopted from respectful maternity care recommended by WHO. इसमें patient की we have to safety, dignity, confidentiality हमें maintain करनी है, ensures freedom from harm and mistreatment. As a medical student, जब हम medical ethics पढ़ते हैं, उसमें ये है कि you have to do no harm. आप पेशेंट का भला बाद में करोगे, फर्स्ट आपका प्रिंसिपल होना चाहिए कि हमें अननेसेसरली सर्जरी या कुछ नहीं करना है जिससे कि पेशेंट का बुरा हो. तो पेशेंट की सेफ्टी, डिग्निटी, कॉन्फिडेंशियलिटी हैज टू बी मेंटेन एंड इन्फॉर्म्ड चॉइस. गिव हर ऑल द ऑप्शंस and let her make the decision of the method of medical abortion, and continuous support during and after all types of abortion. क्योंकि सपोर्ट बहुत जरूरी है, बिकॉज फॉर अस इट माइट बी रूटीन प्रोसीजर, लेकिन पेशेंट के लिए हो सकता है कि लाइफ टाइम इवेंट हो. अगर एनाल्जेसिया ठीक से नहीं दिया है तो इट माइट बी पॉसिबल कि पेशेंट को वो लाइफ टाइम याद रह जाए, या किसी ने उसको मिसट्रीट किया हो, इल ट्रीटमेंट किया हो, या कुछ वर्बल अब्यूज किया हो एट द टाइम ऑफ व्हेन शी इज एक्सपेक्टिंग एन अबॉर्शन services at a healthcare provider. So that is respectful abortion care. So it is, we as a provider or as a patient, we have to treat with dignity, empathy, compassion. उसे हमें प्यार से डील करना है, irrespective of her race, irrespective of her gender, irrespective of her socio-economic status, rich economic status से है या poor है या religion है, या उसके कितने abortion हो चुके हैं, pregnancy है, miscarriages हैं, because we have overheard many busy resident doctors जो थोड़ा सा कभी गुस्से में या busy होते हैं तो बोल देते हैं और कितने बच्चे करोगी, या ये तो करती जा रही है, या बस that we don't have to do. If you ever feel that something isn't right, speak up. As health professional, it's our duty to listen and support. Communication is the key. So communication is a two-pronged things. We have to speak and we have to listen. उसकी भी बात सुनिए, उसको support कीजिए. हो सकता है उसके मन में कुछ doubts हो, तो we have to clear those doubts. हो सकता है particular methods of abortion उसने अपनी किसी पड़ोसन से सुना हो कि उसको medical abortion में problem हुई थी, या surgical abortion के बाद लोगों को रहता है कि infertile हो जाएंगे. तो you have to clear all their doubts. So communicate कीजिए. What are the norms and stigma? We have a separate video for this. So what are the stigmas and norm? Disrespect and abuse. Whenever a lady comes to us for a
Madam, sorry to interrupt you. Madam, there was a video earlier, madam. Earlier slide.
Yeah, I will show both the videos at the end. ये
Okay,
वाला
ma'am.
वीडियो इसमें अभी
Yes,
चलेगा
ma'am.
कहाँ? नहीं चलता है. ठीक है, तो फिजिकल अब्यूज हो सकता है. वैसे इट्स वेरी रेयर कि स्लैपिंग या फिजिकली इंटिमिडेटिंग या फिर वर्बल अब्यूज, जैसे कि कुछ नॉन ऑफेंसिव लैंग्वेज, शाउटिंग, स्क्रीमिंग. बिजी हेल्थ केयर फैसिलिटी पे वो पहुंच गई है जहां ऑलरेडी 3-4 या कई अबॉर्शंस होते हैं, तो हेल्थ केयर प्रोवाइडर में नॉट बी इन ए मूड, या उसका टाइम एकदम जब निकलने वाले हो तब आ रहा है. या सेक्सुअल अब्यूज, सम पीपल में टेक abuse of their power or take advantage of it. Then we have a saver video also. And अगर हम अपने professional standards को meet नहीं कर पा रहे हैं, that is also a failure. Then we have to maintain a good rapport with the patient and the doctor. So if it is poor rapport, that is also a stigma. And if we are not able to provide proper health system conditions and constraints, because may not be it's possible कि हमारा उतना sterilization नहीं हो, या जो facilities patient को available होनी चाहिए वो नहीं है. So what is the right of every woman? Freedom from harm and ill treatment. We cannot ill treat any woman just because she has come for abortion services. She has the right for information. She is protected under laws, MTP and POXO law. Agar if she is less than 18 years of age, then we need to inform the POXO. Informed consent and refusal. She might refuse for any particular method of abortion. Respect her choices, respect her preference. Quality of care is to be given to her. Maintain her dignity. And right to timely health care. Timely, we have to see her and highest attainable level of health, liberty, autonomy, self-determination and freedom from coercion. मतलब हमें उसके साथ कोई भी जोर जबरदस्ती नहीं करनी है. It's her choice. We don't have to we have to उसको basket we have to provide them, और उसमें से वो choose करेगी कि उसे क्या करना है. So what are the domains of respectful abortion care? जैसे कि being, इसके 12 domains हैं. Being free from harm and mistreatment, maintaining privacy and confidentiality. अभी जो latest MTP का amendment है, it has also said that confidentiality has to be maintained. We cannot breach the information to anybody. Preserve her dignity, उसकी choice को, effective communication, soft skills, because communication is the most effective key. अगर आपने कुछ किया लेकिन आपने कम्युनिकेट नहीं किया, देन इट्स अ बिग एक एम्प्टी बास्केट की तरह हो गया जिसमें से पानी लीक करता रहेगा, बिकॉज पेशेंट को पता ही नहीं है कि जो उसे आइडियली हमें बताना चाहिए था. Providing information and seeking informed consent, ensure continuous access to support throughout the procedure. When she comes to us, उसको एक support system होना चाहिए. Quality of physical environment and resources we have to provide. Providing equitable abortion care and competent होना चाहिए provider, motivated होना चाहिए, and contraceptive advice should be given at the end, and counseling is the most important, and continuity of care. So time to strengthen implementation. So one important change, as we can see, up to 20 weeks, only one provider is there, or from 20 to 22 weeks, we need the consent of 2 RMPs, or 24 weeks के beyond, at any time, medical board की opinion is required. अगर medical congenital abnormalities या इस तरह का case है, तो up to 20 weeks की most common cases होते हैं, तो one provider. So more responsibility comes to us, because we have to counsel them, we have to give them advice about contraception, we have to give them compassionate care. As you can see in the second graph, there are expands eligibility, especially young people, survivors, unmarried. Everyone needs unbiased care, and we need to overcome our own biases. 20 वीक्स तक सारी वुमेन है। स्पेशल कैटेगरीज जैसे कि डॉक्टर यशोदा प्रदीप मैडम ने बताया कि रेप विक्टिम्स हैं, उनको 24 वीक्स तक वी कैन गिव, और लेस देन 18 ईयर्स है, माइनर है या और कंडीशंस है। बर्थ डिफेक्ट्स में देयर इज नो लिमिट फॉर जेस्टेशन एज एंड मीटिंग ऑफ बोर्ड इज रिक्वायर्ड, और बोर्ड को 3 days के अंदर दे हैव टू डिसाइड। So we need to be judgment free. We need not judge her कि ये 3 कर रही है या 5 abortion हो रहे हैं. We have to give them timely services. Then prioritize confidentiality and safety. Respect begets respect. We are always taught in this thing कि respect begets respect. So providers, we need to be mindful of socio-cultural aspects. उसके एरिया में क्या चलता है, उसके cultural क्या है. So confidentiality, name and other particulars of any woman seeking abortion are to be kept confidential except to a person authorized in any law for the law time being in force. And the ground of failure of contraception extend ho gaya hai to woman and her partner. Yes. ये WHO Saver की वेबसाइट पे you can click this link and there are certain games and so with this 1971 में जब abortion law initiate आई थी तब हमारा concern था unsafe abortion का. Now in 2000 we moved on to safe abortion and now in 2020 our focus is on respectful abortion care. So we have certain questions and I would like कि जो participants हैं वो उसका आंसर दें कि according to WHO restricting access reduces the number of unsafe abortion, true or false? What do you think? अगर हमने abortion की access को reduce कर दिया तो number of unsafe abortion भी कम हो जाएंगे.
False सही.
False.
False.
Okay, it's good that all of you have it is false क्योंकि we have to increase the access so that number of unsafe abortions कम हो जाएं. जितना access मिलेगा लोगों को उतना ही abortion unsafe कम होगा. Second question, a 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it's your responsibility to tell her to continue this pregnancy. Yes or no?
No, no, no.
No.
Anyone else?
No.
No, no.
Yes. We need not, हम उसे समझा सकते हैं just कि it's a 22 weeks window है, but it is her choice. We just can give a basket of opinion, but it is not our responsibility to tell her to continue this pregnancy because it is, she comes under special category. This has been created that recently widowed. It's just that we have to take as a practitioner. We हमें 2 RMPs की opinion की जरूरत पड़ेगी इस case में. So with this, we have Samarth, safe abortion made available respectfully throughout health system. We have 2 videos to see.
Before you start the video, Ruchika, Madam Saroj Singh is there.
Okay, welcome, Madam Saroj Singh. We are happy to have ma'am as guest of honor today.
Yes. Good afternoon, Madam. Thank you, Madam, for joining. Madam, may I have, ma'am, can I introduce you?
Ruchika, why are you?
No, ma'am, it is not her log talk. There are 2 videos now only. Now after that, so ma'am, you yes.
So first of all, I apologize for joining late because we had some important meeting with Madam at the same time. I really congratulate Dr. Savita, Aarti, and all the organizers for choosing particular this subject for webinar, that respectful abortion care. Because many times we are discussing so many complications of pregnancy, PPH, and all that, but abortion is missed many times. And once amendment has occurred in MTP Act, now it has become very important that we understand all the changes which have occurred and how to overcome the when we are dealing with these cases in our practice. And I am 100% sure that Yashodhara ji has explained them very nicely. Very nice senior of me, Yashodhara ji, namaskar. And I also pay regards to Shanta ji and Dr. Madhvi Patel, Dr. Jaideep, and all the others who are here. But all these topics which have been taken care of which IRT sometimes they will be of great help, because abortion is a thing which is her own right. And it's very important that even for abortion, it's not essential that we have to take consent from the husband. But whenever it is below 18 years, of course, guardian's consent is required. But what amendment which has occurred that we can do even up to 24 years, and whenever there is pregnant anomaly, we can do even after that, then the things become much more easy. Because it was only last, I think 15 days back, we had a patient of rape who had 28-week pregnancy. In from Lady Lyle, they were insisting that again and again that now amendment has come. So then committee was made. You cannot do it at 28 weeks when there is no anomaly. So these are the things which we have to understand very clearly, and I am 100% sure that this webinar will be really very.
Please mute.
Thank you so much, Savita, for giving me this opportunity to be.
Thank you, ma'am. Thank you so much. We are blessed with your blessings. Thank you so much, madam. We need your support and guidance in future.
All of
also.
you are doing so very nice. Very
Thank you, madam. Thank you so much.
Okay.
Ma'am, please stay for a minute. I'm taking one photo.
I'm here, no problem.
Thank you, madam. Thank you so much. Okay. So now we have to proceed for Ruchika. You proceed for your these videos. You just start. Share your video. मेरा कुछ आ रहा है क्या?
मैम वो चल तो रहा है वीडियो, एक सेकंड में देखती हूँ दूसरा.
Human will play if you are not able to play.
Meanwhile, I want to ask one question. Can I ask?
Yeah. Yes.
This amendment, ये तो हम डॉक्टर्स की लगातार ट्रेनिंग हो रही है, तो we all know about this. क्या जनरल पब्लिक को भी इसके बारे में कुछ पता चल रहा है कि 20 से 24 वीक्स तक लीगली हो गया है उनके लिए, तो उन तक इंफॉर्मेशन कैसे पहुंचेगी?
एक्चुअली में जो भी ये चीजें हैं ना, ये सब मीडिया में भी पहुंच जाती हैं, है ना. और जब पेशेंट हमारे पास आता है कि वो तो ये भी तो पता ही नहीं होता कि कहाँ तक प्रेगनेंसी को टर्मिनेट करा सकते हैं कि नहीं करा सकते हैं. जिसको भी जरूरत होती है वो आपके पास आता ही है, जो भी परेशानी में होता है, whether she is raped by the rape or because she is minor or she is not having her mentally retarded girls are being brought to us. हमारे पास लाई जाती है ना, जो इनका दिमाग नहीं है, कमजोर है, 24 हफ्ते हो गए, पता ही नहीं चला, 20 हफ्ते हो गए, तो उनको तो जिनको परेशानी होगी वो तो हमारे पास खुद ही आता है डॉक्टर संगीता, है ना. तो हम लोगों को तो नहीं, मतलब हम लोगों का तो इसमें बहुत ज्यादा कुछ रोल नहीं है. हमारा तो ये रोल है कि अगर ऐसा पेशेंट हमारे पास आता है तो हमें करना है. वी शुड नॉट मोटिवेट फॉर द एमटीपी, बट वी हैव टू हेल्प द लेडी, है ना. हमें हमको ये मोटिवेट नहीं करना है कि आप 20-24 हफ्ते तक रुके रहो फिर अबॉर्शन कराओ, है ना. उनको पता होगा तो ये लोग ना और ज्यादा टाइम ले लेके फिर आपके पास आएंगे. तो वो तो कोई, मुझे नहीं लगता कि उसकी हमें जरूरत है. जो नीडी है वो तो अपने आप ही हम लोगों के पास आते ही है ना. आप लोगों के पास भी आते होंगे वहां पर ना, सहारनपुर में, नहीं क्या? तो आपको लगता है कि इसकी जरूरत है हमें?
I think, ma'am, it's not necessary. Because who need, they come.
ये वीडियो की थोड़ी आवाज कमी है,
बढ़ा तो आ जाएगी.
Madam, shall I play the video?
Yeah, better, because
There
there
are the
is no
settings
voice.
actually. Before you play a video, you have to do the settings, madam. That application. I'll play the video. You stop share the.
Stop sharing.
Madam, please stop share the screen, madam. I'll play the video. Richika, ma'am. Please stop the video, madam. We can't hear. There is no audio, madam. Only video is playing. I'll play the video.
Yes, you play. Ruchika is there?
Yes, ma'am. Madam has to stop share. I can share video.
ये भी साफ नहीं आ रहा क्या?
हाँ, तुम इसको ना स्टॉप शेयरिंग कर दो, शेयर कर देंगे दोनों, है ना? हाँ, you stop share.
Norms and stigma वाला करना है.
हाँ. You will start.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others. personally and professionally. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high-quality medication, information and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps, provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high-quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various
Shriman, are you there? Aarti ji, you start your screen sharing, I think. Now, this module will be taken by Dr. Aarti. She is the president of Agra Obs and Gynae Society and chairperson of past chairperson of Club 35 IMS and Secretary General elect IMS India.
also known as SDGs, Building Resilient Health Systems for Universal Health Coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Seva is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
अपना वाला स्टार्ट कर लीजिए आरती जी वाला फैमिली प्लानिंग.
हाँ वही तो मैं पूछ रही हूँ ना, स्टार शेयर कर सकती हूँ ना?
हाँ कर लीजिए.
तो कह रही मेरे पास पैसे, तो तुम दोनों की दोनों गूंगों की तरह क्यों खड़ी हुई हो? पागल हो क्या? सर के हुए हो क्या? टोटली मैं कह रही हूँ कि पैसे ले लो तो कह रहे हो कि वो लेने जा रही है.
सविता आ गया ना?
नहीं आया.
नहीं आया?
हाँ मैं करूँ शेयर?
हाँ तुम करो.
मेल वगैरह खोल.
मैं कर दे रही हूँ शेयर.
करो.
अब आप बंद कर दो, शेयरिंग बंद करो, आप शेयर स्टॉप शेयरिंग करो.
1 मिनट में जरा देखूं आ गया क्या? अब आया?
नहीं आया.
ठीक है तुम करो.
आप स्टॉप शेयरिंग कर दो पहले.
कर रही हूँ. कर दिया
हो गया?
हाँ आ गया फुल स्क्रीन कर रहे हैं
वही मैं कर रही हूँ। अभी तो दिक्कत हो जाती है मेरी भी। अरे यार हो गया फुल? नहीं हुआ ना अभी फुल शेयरिंग? फुल नहीं हुआ ना?
नहीं
Madam, still in PPT only, madam.
हाँ
It's not full screen, madam.
उनसे बोलो निरंजन कर देंगे
हाँ श्रीमन आप कर दो।
श्रीमन आप कर दो
Okay, ma'am.
कर रहे हो आप? श्रीमन आर यू डूइंग?
Yes, madam. Yes.
Okay, you do. I am stopping. Okay, I am stopping sharing. You start sharing.
The screen visible, ma'am.
And allow Aarti ji to move the slide. Na, that will be better.
Madam, please say next one. I'll change the slide from my end only.
Okay. It is.
yes now I can start
Yes.
now I am going to speak on the pre and post abortion family planning counseling leveraging technology for referrals and online consultations. Next, now we should know the next is the problem. What is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. In fact, what is counseling? Counseling is a thing which we should understand. That this is an atmosphere in which a patient can open to you. The patient can talk to you whatsoever she wants to talk. She can ask any question. You can develop a rapport with the patient so that patient can tell each and everything about herself to you. So the most important thing is the counseling and the rapport between the patient and the doctor. Next. Now, what is the pre-abortion counseling? And it's an integral part. It is an integral part of comprehensive abortion services. Because counseling is an integral part for the, yes, thank you. Pre and post abortion counseling. What is pre and post abortion counseling? It's an integral part of comprehensive abortion services. And counseling is as important as the procedure. Counseling is important as women may need help in decision making, and whenever needed, the spouse should also be counseled. Next, Shriman. Now, what is the critical role of pre-procedure counseling? What is pre-procedure counseling? Pre-procedure counseling is the help, ensure, and help. And this is very important. In this, we have a critical role. We have to help the woman to decide about the termination of the pregnancy. Okay? This is the most, at times the patient to decide about the termination of the pregnancy. Okay? This is the most, at times the patient is coming to you and she is unable to decide she should continue the pregnancy or she should terminate the pregnancy. So there is doctor who is having a very important role so that she can counsel the patient that you should continue or you should terminate what is in her favor. The another help to the woman, when once she has decided that she will go for the termination, then we have to help the woman to choose the method of termination. What should be the method of termination? Third thing is this, we have to ensure the patient, we have ensured the delivery of complete information about the procedure, each and everything, plus and minus, both sides of the procedure, we have to tell the patient so that patient can understand what is the side effect of this abortion and what are the advantages of this abortion. And the another thing is the help, and we have to help the woman to adopt a contraceptive method after the abortion is complete. Next. Now, what is the procedure of pre-procedure counseling? Pre-procedure counseling, the most important thing is we have to ensure privacy and confidentiality. And the second thing is this, we should be non-judgmental and we have to be sensitive when we are talking to the patient about her methods. Then we have to establish a rapport, I have already told you. And we should use always a simple language. We should use the language which patient can understand. If patient can understand the Hindi, we should speak in Hindi. Can understand English, we should speak in English. If she is from some local area, so we should try to speak in her language if we can do that. And after that, if she has made up her mind for the termination of her pregnancy, then assess her for the procedure. Next. Now, what is the relevance of the peri-abortion family planning counseling? The most important thing is this, we have to tell the patient that there is the quick return of the fertility. If she will not go for the contraceptive method, so she may be pregnant even in 1 month, even within 30 days, within 10 days. So we have to tell the patient there is a quick return of the fertility. Minimum, there should be a minimum of the 6-month gap before the next pregnancy, because this 6-month gap is very important for her, for her health benefits and for the better future pregnancy outcomes. Because in these 6 months, she will be able to come out of the abortion weaknesses and she can maintain her body as she want to maintain. She can maintain her hemoglobin and other things. So it's very important for her health that she should have a gap of the 6 months before the next pregnancy. And the most important thing is this, that this is the opportune time for the contraceptive acceptance. As patient is just going through the abortion, this process, which is a traumatic process for the patient, so this is an opportunistic time that we can counsel her for the contraceptive acceptance. And the most important thing which we should remember is this, that 90% of the abortion-related maternal mortality can be prevented by ensuring the contraception. So we all gynecologists, most of the time we does the DNC and we leave the patient. We never counsel the patient that she should go for the contraception as well. So which is a very important part. If you will do that, then you will be able to provide the contraception to the females. Next. Now, what is pre-abortion family planning counseling? When to start? We have to start on the first visit when she is coming for the consultation. Whenever if there is any exception, suppose there is some grief management, there is a loss which the patient is unable to bear. In that case, we can leave at that time, at the first consultation. We can counsel her later on. What to counsel? Most important thing, we have to tell her that fertility may return between 10 days to 4 weeks. Even the patients are coming the pregnancy in the same month. She has got the abortion and the pregnancy in the following month. So we have to tell the patient if she can have the pregnancy in the same month. We have to help her with the choices. We can provide her on the cafeteria of the contraceptives. We can, suppose she is interested in some particular method, then we can tell her about the specific, we can provide her the specific counseling regarding that method. And we should also tell the high-risk behavior whenever applicable. Here we have to remember that if the woman is not willing for any contraceptive method, so we cannot refuse for MTP. We should not refuse for the MTP, because MTP, we have to provide an MTP. This is very important. We cannot say if you are not using the contraception, I am not doing the MTP. This is very important. Next. Assessing suitability for the post-abortion contraception. whenever we are providing the post-abortion contraception, so we have to see that abortion process is complete, there is no existing infection, there is no injury to the genital organs, and chances of fresh pregnancy should be ruled out. Suppose patient is coming to after some time, there is a gap before arriving to you, then we should always see that there is no fresh pregnancy in that patient. Next. Now, what is the critical role during the post-procedure counseling? The critical role of a doctor, we have to ensure the woman that women should understood the precautions and care needed during the post-abortion period. So the patient should know what precautions she should take and what are the post-abortion care. The opportunity to counsel for contraception in case not previously accepted. Patient ने यदि पहले नहीं उसने contraception accept नहीं किया है, तो when she is coming after post abortion to a next visit for the follow up, then we can advise her to the contraceptions, and we should reinforce the need for continuing the use of contraceptive method chosen. If she has chosen some method, so we should ensure that you should continue this, you should not leave this method. Next. Now, what is the procedure for the post-procedure counseling? The procedure for the post-procedure counseling is the continue, reassure, and repeat. We have to continue to ensure privacy and confidentiality. We have to reassure her in case of any problem. She is having any problem related to her genital organ, we should reassure her. And another thing, we have to repeat the information about the post-procedure care and danger sign. Suppose she is having bleeding, she is having foul smell discharge, so we have to counsel her. If she is having any danger sign, so she should consult to his doctor, to whosoever her doctor, she should consult to her. Next. Now, what is the post-abortion family planning counseling? Suppose patient has already opted some method, we should appreciate her. We should appreciate it's very good that you have opted in contraceptive method. We can provide her immediate care in the form of IUCD or Medoxy progesterone acetate. We can ask her to go for the ongoing method like oral pills. We can follow up the protocol, and we can advise her to continue her contraceptive. If she has decided any method, so she should continue the method. And the most important thing, we can give her the cards, especially in case of Medoxy progesterone acetate, in which we can provide her the next date of the injection. So you are supposed to come after 3 months for this injection, so we can provide her the cards as well. So these are the already opted method what we can advise her. Suppose patient is still undecided. If patient is undecided, then at first we have to allay her anxiety. She should not be anxious, and we should tell her what is the importance of immediate adoption and choosing of the contraception. And what we can do, we can tell her, today you are not ready, you can come to us after 1 week, then we can talk about the contraception. So we can extend the period of adoption, because there are the chances that patient may be ready at the next time when she is coming after 1 week. And after that, even we can counsel the couple for the contraceptive methods. We can counsel that you should go for the contraception at least for the 6 months before planning the next pregnancy. So we can counsel her, or up to the time till you are not wants any pregnancy. And at last, even if patient is not ready for anything, so then we can advise her emergency contraceptive pills as a method, and we should tell her how she should use the emergency contraceptive pills so that at least she can avoid the unwanted pregnancy. Next. Now, what are the post-abortion contraceptive methods? And the first and most important is the barrier method, which are the condoms. And condoms can be used as soon as the sexual activity is resumed. Even in the first trimester and also in the second trimester, the condoms can be used as soon as the sexual activity is resumed. And we should tell the additional advantage and additional information related to the condom. What we should tell her, it's non-hormonal, there is no hormone side effect, can be used without consulting a health provider, and easily available. It prevents against sexually transmitted infections, including the HIV, and enables men to take responsibility of the contraception. Condom is a method in which the man is responsible for the contraception. The another method which we should talk about, the intrauterine contraceptive devices. We all of us know that we have the IUCDs in the form of 380A and IUCD 375. The one thing which we are supposed to remember here is this, that we can insert immediately after the procedure. All of us know that we can insert immediately after the procedure. And the another thing which is very important, that we can insert up to 12 days after confirmation of a completed abortion. If we are sure that your abortion is complete after the surgical method, so you can apply the copper T till 12 days after abortion. And in case of the medical management of abortion, you can apply the copper T on the day 15th of the process, provided we have to see that complete product of conception should be expelled. There should be no product of conception. There should be no incomplete abortion should be there. And we should exclude the contraindications as well. Even in the second trimester, we can insert immediately or up to the 12 days after the procedure is completed, and contraindication should be ruled out. And what is the additional information? The additional information is this, that this is highly effective, provides long-term contraceptives for 5 years for IUCD 375 and for 10 years for IUCD 380A. It can be provided by the trained doctors, MBBS and above. ANMs, nurses, after first trimester surgical abortion can provide the copper T insertion. By trained doctors only after medical management of abortion, because it's very important that we have to look, is there complete abortion or not. If there is complete expulsion of the product, then you can apply the copper T. So it should be applied by the doctors only. And by PP-IUCD trained doctors after second trimester abortions, the copper T can be applied. There is no interference with the sex and immediate return to the fertility after taking out of the copper T. Next. Now the next method is the hormonal contraceptives. We know we have the combined oral contraceptive pills. The most important thing is here, which I came to know, is this, that you can start the contraceptive pills up to 7 days after the abortion using the surgical method. Within a week, you can start the contraceptive pills. And the most important thing is, which we should all remember, is the after medical management of the abortion, it can be started on the day 3 with the dose of misoprostol, or within day 15 of the process after confirmation of the completion of the abortion. So either you start on the 15th day or on the 3rd day after the medical management of the abortion, on the day of the insertion of the misoprostol. This is very important. We should all remember this. And in the second trimester, we can start immediately or up to the 7 days after abortion. And what are the additional information? The most important thing is that it regulates the menstrual cycle. It can be provided by the all health worker after the first screening by the trained provider. The first screening should be by the trained provider, then any health worker can prescribe the oral contraceptive pills. No interference with the sex, offer protection against the ectopic pregnancy, endometrial and ovarian cancers, and benign diseases such as fibrocystic and fibroadenomatosis. The oral contraceptive pills हमको बचाती हैं इन सारी बीमारियों से. It's not suitable for the women who are breastfeeding babies less than 6 months old. This is very important because it will decreases the lactation. This will decrease the milk quantity and quality. So we should not use in initial 6 months when the patient is pregnant. We should use the only progesterone pill in the initial 6 months for the patients. Next. Now we are coming on the long-term injectables, Medoxy, Progesterone, Acetate. This is also very important. We can use it immediately up to the 7 days after abortion using surgical method. And after medical management of abortion, it can be started on the day 3 with the dose of misoprostol. This is very important. We should remember that we can start on the day 3 on the dose of the misoprostol. in the second trimester, we can immediately start it or can be given up to the 7 days after the abortion. And what are the additional information are there? This is highly effective. Confidentiality and privacy is maintained, can be provided by doctors, MBBS and above, Ayush, ANMs, nurses, after screening by the doctors for the first injection. This is very important. Whenever you are going to start any method, the first screening should be done by a doctor. There is no interference with the sex, no effect on the quality and quantity of the breast milk, no estrogenic side effects. So you can use it very well in the patients who are diabetic, who is hypertensive and who is obese. In those patients, we can use it, and it offers protection against ectopic pregnancy, ovarian cancer, etc. Next. Now we are coming on the permanent method. We all know the permanent method is the female sterilization. It can be performed after an abortion in the absence of any infection or severe blood loss. Because we usually do MTP ligation together, but we should remember two things. There should not be any missed abortion. There is infection. We are talking about the MTP, so we can do it with the MTP, but the hemoglobin level should be all right, and there should be no concurrent infection with the to the patient. Concurrently or up to the 7 days, we can use both mini lap and laparoscopic sterilization can be done. With medical management of abortion, it can be done only after the first menstrual cycle. So this is very important. We will do after 1 month if we are doing after the medical management of the abortion. In second trimester, mini lap sterilization can be performed concurrently or up to the 7 days after an abortion in the absence of any infection or severe blood loss. Laparoscopic sterilization is not recommended. We cannot done the laparoscopic sterilization in the second trimester abortions. And what is the additional information? Permanent method of contraception, highly effective immediately, no interference with sex, no effect on breastfeeding, no long-term side effects, and offers protection against ovarian cancer. And another thing is the vasectomy, performed on the males independent of the timing and procedure of the abortion. It's very effective, permanent method of contraception, and no interference with the sex. Next. Now, this is the method which we can, इसको जरा clear करो आप. We can use the COCs and injections and contraceptive method with medical management of abortion. These are the contraceptive methods. We can use the combined oral contraceptive pills on the day 3 and Medoxy, Progesterone, Acetate injection on the day 3, and even the Sandchroman can be used from the 3rd day of the abortion. And IUCD you can apply after 15 days. This is very important, and I have told you tubal ligation you can done after 1 month of the when the patient has the next menstruation. After that you can do the tubal ligation. Next. Now this is the contraceptive method with vacuum aspiration. You can see these are almost the same. So you can start the COC injection and send within the 7 days of the abortion. IUCDs can be given within a week or up to the 12 days, or you can total tubal ligation can be done after the vacuum aspiration. Next. Now we are coming on the SRS services, I mean the tele consultation and other technology. Next, we have used the tele consultation so much in the time of the corona, and in fact the tele consultation is coming in our scenario after the corona. What we can do tele consultation, tele counseling, tele guidance, tele references, and tele linkages. So we can do all these things by the technology, and it's a very good provision to provide the services to the patient when patient is at home, and she can take the consultations from you on the phone, and her visit to the hospital may be avoided. Next. Now, what is the leverage of technology? You know, we can use the websites like Hamdo, social media like Ask Tanu, YouTube, infographics are there, helpline is there, and the most important thing, there is the patient education platforms which were made by the WHO, MOHFW, and RCOG. So now the patient can access these platforms and can gather the information which is up to the mark. Suppose whenever we are going to the Google, we don't know which information we should take and which information we should not take. So I think these are the platform from where you can take the information. Next. Now, what is the SWOT? SWOT is the strength, weakness, opportunity, and threat. And as we know, we are using the telecommunication from the COVID era. It's approachable throughout the process, and it gives the confidence, and it spreads awareness, especially spread out questions answered at ease. Whenever you are asking any question, so we can answer it. You have the awareness on this. So I think this is a very good method to do the awareness and to provide the help to the patients. The weak point of this teleconsultation is we cannot communicate face to face, and we cannot demonstrate anything to the patient. If we want to demonstrate by some chart, by some card, so we cannot demonstrate the practical thing we will do like this. So this is the weakness of this. And the opportunity, what is the opportunity? It's a cost saving, number of the visits are cut down, and privacy and comfort. The privacy is maintained and very comfortable. You are at home and you are getting the prescriptions on the phone, so it's very easy for the patients. And the threat, what is the threat? The threat, the most important thing by which we don't want to use it, this is the time of the medical legal, we can miss the opportunity and we can misdiagnose. So these are the two things which we should keep in our mind. Whenever you are doing the teleconsultation, you should always keep in your mind, if the patient is supposed to call at your clinic, then you should call her at your clinic. If you feel you can give the teleconsultation, so then you can do the teleconsultation and you can avoid the visit of the patients at your nursing home. Next. Now, applicability of component of comprehensive abortion care. What is the applicability? There is assessment, confirm the diagnosis, and we want contraceptive need. These are the three things: assessment, confirm diagnosis, and contraceptive need. Then counseling. Counseling can be done by the video conferencing or by the Zoom, and follow-up. So during abortion care, we have to give the hybrid services. Minimum one visit should be there whenever she is coming for the abortion, and in the medical management of the abortion, 3 visits should be there. First consultation visit, we have to confirm the pregnancy, then we will provide the medicine, then she has to come after 1 week. So there are the minimum 3 visits in the medical management of the abortion, and 1 visit in the other problems. So we have to keep in our mind that we can give the comprehensive abortion care, and we can include the teleconsultation with us. Next. So now what are the key messages? So now we should understand and we should realize the need of post-abortion family planning counseling. If we will provide the patient post-abortion family planning counseling, we are providing the abortion, the contraceptive methods. The patient is more acceptable for the contraception after delivery and after abortion. Second thing, bring the couple on board and strive for 100% coverage. We should try our best to provide the contraceptive devices, because we have to think in that sense, if we are providing the contraception, so ultimately we are decreasing the mortality related to the abortions in our country. So this is very important. And the third thing is capitalize on the basket and applicability in post-abortion period. So we should give a cafeteria of the basket of the contraceptive which she will choose, and then we should tell her what method she wants to use. So we should always give all the options of the contraception. Technology, as far as possible, scope for entry in comprehensive abortion care services, concern as the policy, malpractices, service cost, and access. And the last point, which is very, very important, adolescent needs both online and offline. We should fulfill, we should keep in our mind that adolescent health is very important, and we can give the consultation online or offline. We should always consider our adolescent, because they are the future citizen of our country. So we should always keep in our mind. These are the key messages for this. And next. So now this is very important. You should do the registration and pre-test is given, and after that you are supposed to give the post-test and feedback. And after giving the post-test and feedback, you will get the certificate which will be awarded to you for the participation on attending the training and submission of registration of pre-test, post-test and feedback. Then you will get the certificate. Otherwise, you will not get the certificate. Thank you. Thank you so much.
Thank you so much, Dr. Aarti. Some questions are there. Please take these questions. There is one question by Dr. Ratna. Ultrasound is necessary before going for medical abortion of pregnancy?
No, not necessary. You are not supposed to do the ultrasound for the medical abortion of the pregnancy. You can give the medicine.
But a patient comes with this ectopic pregnancy, rupture ectopic pregnancy.
Actually,
are you not supposed to be
guidelines
to court of law?
नहीं, गाइडलाइंस ये कहती हैं कि आप इनिशियली मेडिसिन दे सकते हैं, उसके बाद यदि आपको कोई प्रॉब्लम होती है, देन यू शुड गो फॉर द अल्ट्रासाउंड. कि आप इसकी गाइडलाइंस पढ़ेंगे तो सब में यही दे रखा है, मेडिकल मैनेजमेंट ऑफ प्रेगनेंसी में यही दे रखा है.
For our safety, there is no harm in doing ultrasound, because if there is an ectopic pregnancy, we can land up in a big trouble.
नहीं, देखिए ऐसा है, एक्चुअली मोस्ट ऑफ द टाइम तो ऑल ऑफ अस हैज द अल्ट्रासाउंड मशीन्स. द पर्संस हु आर नॉट हैविंग अल्ट्रासाउंड मशीन्स, persons who are not doing ultrasound, so it's very difficult to say to the patient just to go for the ultrasound, then we will give you the medicine. So I think medicine should be prescribed. If there is any problem after that, the patient is having any pain or any other, but this is written in the book which I am telling you. If patient is having any problem, then you can send her for the ultrasound. So,
what I suppose, if patient is coming to the primary health center, then these guidelines are okay for her, for the government doctors. But if she is coming to us, we should go for, if it is pregnancy is very early and we are in doubt whether it is in intrauterine or and extra, we are not sure, then we should go for the ultrasound.
हम लोग सब यही करते हैं because we are having ultrasound machine. हम
लोग तो यही बोलती है कि हम लोगों को कर लेना चाहिए. अगर आप आ रहे हो, पेशेंट आ रहा है 5 weeks 6 weeks पर आप अबॉर्ट दे रहे हो, तो we should go to save our own skin ना. ये सारे जो गवर्नमेंट की गाइडलाइंस हैं, these are all the primary health centers for government sector. These are fitted for them. अगर हम प्राइवेट वाले करेंगे ना, तो हमारे ऊपर तो बहुत सारे केस लगेंगे. तो हम लोगों को तो कर लेनी चाहिए कायदे से. रत्ना जी, मेरा तो ये विचार है कि हम लोगों को अगर we are not sure, we should go, because sometimes patient is coming after the cesarean and scar pregnancy is there, we have to exclude that also. तो मैं तो इसलिए करवा लेती हूँ. मुझे लगता है ज्यादातर लोग करवा ही लेते हैं.
नहीं, मैं भी
आरती जी भी करवाती हैं.
मैं खुद करती हूँ, वो कोई प्रॉब्लम नहीं है, लेकिन मैं गाइडलाइंस बता रही हूँ कि गाइडलाइंस में क्या है.
वो मैं आरती जी, वो मुझे ये लगता है कि वो ना प्राइमरी हेल्थ सेंटर पे जिन्होंने तो उनको भी अलाउ कर दिया है ना मेडिकल मेथड ऑफ अबॉर्शन, दोज हु हैविंग डन ओनली these very few मेडिकल मेथड ऑफ अबॉर्शन अंडर द सुपरिटेंडेंट MMA जिन्होंने किया है सुपरविजन में, उनको भी अलाउ कर दिया है. क्योंकि तो ये बहुत उसको वो बड़ा कर रहे हैं ना अपना.
नहीं, एक्चुअली के लिए मेथड दिया है, 3rd day ऑफ द मीजोप्रोस्ट के दिन से आप जो ओरल पिल्स शुरू कर सकते हैं, या आप डिब्बा लगवा सकते हैं. तो यूजुअली हम लोग ये भी नहीं करते, क्योंकि 3rd day करने का हमारा हिम्मत ही नहीं होती कि कैसे करें. तो दिमाग में प्रीसेट ऐसा है कि भाई नहीं करते. यूजुअली हमें यदि पिल्स भी देनी है तो हम नेक्स्ट साइकिल से देते हैं. तो अब यदि हम चाहें तो वी कैन देख सकते हैं भाई चेंज करके कि क्या इफेक्ट्स मिलते हैं. तो वी कैन डू दैट कि नाउ दीज आर द गाइडलाइंस. तो वी कैन डू कि भाई 3rd day ऑफ द मीजोप्रोस्ट से आप दे दें, ओरल पिल्स दे दें, आप डिब्बा लगवा दें. तो वी कैन डू दैट. मुझे लगता है डिब्बा लगवाने में तो कोई नुकसान नहीं है.
अभी इसमें ना एक सब चैट बॉक्स पे एक है लिंक है, उसको सब लोगों को उस लिंक पे जाना है और उसके बाद ना प्री पोस्ट टेस्ट एंड फीडबैक फॉर्म फिलअप करके ही भेजना है सब. तब ये पूरा कर लेंगे ना, तभी सबको सर्टिफिकेट मिलेगा. तो शो प्लीज डोंट लीव इट. ओके, एवरीबडी हैज टू गो फॉर दैट. देयर इज वन मोर क्वेश्चन. अनमैरिड गर्ल विद प्रेगनेंसी केम फॉर टर्मिनेशन ऑफ प्रेगनेंसी, वेदर टू इन्फॉर्म टू पुलिस और नॉट.
व्हाट इज द एज ऑफ द गर्ल?
या दैट इज वेरी मच इंपॉर्टेंट. इफ इट इज मोर देन 18, then there is no need. If she is less than 18 years, then it is required to inform the police because it comes on the POSCO Act.
हाँ, 18 साल से पहले आपको जरूरत नहीं है ना तो इन्फॉर्म करने की.
18 साल से ज्यादा हो तो
उनके मतलब 18 साल की हो चुकी है तो आपको इन्फॉर्म नहीं करना है, और आपको पेरेंट्स की कंसेंट की भी जरूरत नहीं है। आप सिर्फ मरीज की कंसेंट पे कर सकते हैं, पेशेंट की कंसेंट पे कर सकते हैं, या कोई भी बंदा उसके साथ आ रहा है जो उसकी जिम्मेदारी लेने को तैयार है तो उसके साथ कर सकते हैं। ये हमारे न्यू जो एमटीपी रूल जो नया आया है उसमें ये आया है कि वी कैन डू दैट।
अब सब प्लीज
एनी अदर क्वेश्चन?
और तो मुझे नहीं दिख रहा। डॉक्टर संगीता, हेलो डॉक्टर संगीता।
हेलो मैम।
हेलो संगीता।
प्लीज ऑल ऑन योर वीडियो सो वी कैन हैव वन गुड पिक्चर। आप सब लोग प्लीज एक, हाँ। थैंक यू डॉक्टर रोजी। अर्चना इज देयर।
थैंक यू डॉक्टर सविता।
Yeah.
So, over the
सब लोग
counter,
अपना वीडियो ऑन कर लो। अमन, हाँ यस, हेलो अमन। एनी मोर क्वेश्चन इज देयर?
कल तो दिखा दो भाई कौन कौन लोग हैं।
वही तो मैं बोल रही हूँ।
yes, सब लोग अपने अपने कैमरे खोलो तो सबके फोटो हो जाए।
हाँ।
मेहमान ने क्या पूछा है?
For more than 20 weeks। अच्छा भी लेती हूँ इस क्वेश्चन को, अभी लेती हूँ इस क्वेश्चन। ऑन करो सब कैमरे अपने।
रेखा, पूर्णिमा, रोजी, ज्योत्सना, महिमा, रेनू सिंह, अर्चना सिंगल, सब लोगों को एक साथ बाय बाय बोल देती हूँ भाई, नमस्ते कर लेती हूँ। अभी तक नहीं हुई थी।
बहुत अच्छा प्रोग्राम रहा हम सबका।
पटना जी आप भी कर लो ऑन, क्या बात है ऐसी?
अरे यार वो वापस चला जाता है बार बार, बेचारा फिर
एक बार ऑन कर लो, बस एक बार ऑन कर लो।
महिमा, मनीषा,
हो नहीं पा रहा, पता हो नहीं पा रहा है। दोबारा वो सारे फिल करने पड़ रहे हैं मुझे।
होस्ट ने डिसेबल कर दिया।
क्वेश्चन है, for more than 20 weeks pregnancy we need two doctors opinion from where we get that opinion।
किसी से भी ले सकते हो, अपने किसी भी कुलीग से, किसी के पास भी भेज दीजिए और उससे कहिए वो आपके कागज पे लिख के भेजे टर्मिनेशन, शी नीड्स टर्मिनेशन ऑफ प्रेगनेंसी।
अब इसके लिए एक फॉर्म आ गया, फॉर्म ई, तो उस फॉर्म को फिल करना है, उसमें दोनों डॉक्टर्स के नाम और साइन आएंगे। उसको फिल करके फिर आपको अपने रिकॉर्ड में उसको रखना है, और ये रिकॉर्ड्स में वी हैव टू कीप एटलीस्ट फॉर 5 years। ऑल रिकॉर्ड्स वी हैव टू कीप एटलीस्ट फॉर 5 years।
फॉर्म ई आ गया या आएगा? अभी
आ चुका है, मैं इसको डाल दूंगी। फॉर्म ई भी आ गया है, ई भी आ गया और डी भी आ गया है, more than 24 weeks वाला भी आ गया।
मैडम संध्या ने भी कुछ लिखा है शायद अभी।
मैंने पहले भी डाला था बट लोगों ने इस पे ध्यान नहीं दिया। मैंने एक बार जब पहली वाला अपना किया था REC, उससे पहले भी मैं डाल चुकी। तो फॉर्म में डाल दूंगी, बस ग्रुप में डाल दूंगी, तो सब सोसाइटी वाले अपने ग्रुप में इसको वो कर लीजिएगा, शेयर कर
दीजिएगा जिससे कि जिसको चाहिए
तेज बुखार है।
हाँ। Is there any increased incidence of RPOCs and AV malformation after medical management compared to DNC? One question is there।
नहीं ऐसा तो नहीं है, I don't think so।
आप और लोग अपने शेयर करिए। डॉक्टर संगीता, you share your experiences if it's like that।
Not seen till now।
अभी 2 मिनट बाद बुलाती हूँ।
अनुपम यादव, हेलो डॉक्टर अनुपम यादव।
हेलो मैम।
व्हाट्सएप पे तो बहुत बातें होती रही थी।
Actually, I want to ask for medical board, ma'am. To whom?
मेडिकल बोर्ड बेटा अभी
अब हमारी यूपी का तो भी कोई है ही नहीं,
अभी
बना ही नहीं है, तो हमें वो मेडिकल बोर्ड जो हमारी स्टेट गवर्नमेंट बनाएगी ना, वी हैव टू सेंड द पेशेंट टू दैट मेडिकल बोर्ड before going for the termination of the pregnancy। We cannot do our own, or we cannot made our own medical board कि हम एक अपना अल्ट्रासोनोलॉजिस्ट ले लें, एक पीडियाट्रिशियन ले लें और हम कर दें। No, that should be by the appointed by the state government। Then we have to take the opinion of that।
हमें लखनऊ में या आगरा में CMO लेवल पे इस चीज के लिए एफर्ट्स करने पड़ेंगे, तब जाके मेडिकल बोर्ड बनेगा, क्योंकि पूरी यूपी का एक ही बनना है।
हाय अनीता।
तो जब तक हम वो नहीं करेंगे तब तक नहीं बनेगा।
All the best for you।
हेलो मैम, मैं अंजू बोल रही हूँ। हेलो
बोलो
मैम, पेशेंट जो इनकम्प्लीट उससे आते हैं RPOC से, तो उनको दोबारा से मीजोप्रोस दे सकते हैं या नहीं?
दे सकते हैं। लेकिन ये तो ये कह रहे हैं दोबारा से अबॉर्शन पिल भी रिपीट कर सकते हैं यदि नहीं हुआ तो।
नहीं, जो इनकम्प्लीट होते हैं मैं तो देती हूँ मीजोप्रोस्ट। और हो जाते हैं वो कंप्लीट।
यस,
तो कितने
जरूरी
दिन
नहीं
बाद
है, कई बार क्यूरेटाज करना पड़ता है।
उसके बाद 3-4 दिन वेट करते हैं, यदि 3 दिन में निकल जाता है तो ठीक है, नहीं निकलता है तो फिर एमटी
तो फिर डीएनसी।
यस, आई ऑलवेज रिपीट।
बहुत होते हैं
बिकॉज बहुत सारे लोगों में ना होता नहीं कंप्लीट, जब सेकंड डोज दे दो तो उसमें से जो रह जाती है उसमें से काफी का कंप्लीट हो जाता है,
काफी लोगों का हो जाता है। तो वी कैन
अच्छा मैम, डिम्पा अगर लगा देंगे तो पेशेंट को पता कैसे लगेगा, हमें क्या पता कैसे लगेगा कि इरेगुलर ब्लीडिंग किससे हो रही है? हाँ, हम आई तो थिंक फर्स्ट थर्ड डे पे पीरियड के डिम्पा बाद ही लगाना लगाते थोड़ा हैं। सा
अल्ट्रासाउंड
सही नहीं
करना होगा
लगता।
ना, फिर जब बहुत लंबे टाइम तक ब्लीडिंग होती रहेगी तो।
एक्चुअली डिम्पा के बाद एक तो सबसे बड़ी बात है कि उस समय लगा दोगे तो पेशेंट लगा लेगा, साइड इफेक्ट उसका कुछ है नहीं क्योंकि प्रोजेस्टेरोन है। एंड द मोस्ट इंपॉर्टेंट
साइड इफेक्ट है ना, स्पॉटिंग
स्पॉटिंग तो होती है।
इनिशियली स्पॉटिंग तो आप वैसे भी एक्सप्लेन करते हो, लेकिन मेरा मतलब ये है कि आप कंप्लीशन ऑफ द अबॉर्शन तो आप देखने के लिए बुलाते ही हो ना।
नहीं, मैं सोचती हूँ कि एक नॉर्मल पीरियड हो जाए उसके बाद डिम्पा लगाया जाए, दैट इज व्हाट आई फील। गाइडलाइंस कुछ भी कहें,
प्रैक्टिकली इला हम यही करते हैं, लेकिन कितने लोगों को लगा पाती हो आप? कॉन्ट्रासेप्शन कितने लोगों को दे पाती हो, सवाल ये है।
हाँ, फॉलो अप में लूज हो जाते हैं, यू आर राइट।
यदि हम ये चाहते हैं कि हमें अपने यहाँ पे कॉन्ट्रासेप्शन कम से कम 6 महीने मिनिमम सेकंड प्रेगनेंसी से पहले देने ही देने हैं, तो वी कैन
तुरंत ही
आज ही लगवा लें।
Shriman, please post the link again. Ask, people are asking to post the link again. I think it is there in the chat box. Please go to the chat box.
It is in the chat box. I have completed.
Yes, that is, this link is there.
Yes.
Sarita Didi, it is very important for contraception advice because it has been seen that even after 8 days of abortion, patient has ovulated.
Patient can get pregnant.
Yes, in the very next cycle, patient comes with a pregnancy, fresh pregnancy.
और हम लोग क्या करते हैं, मैंने व्हाट आई फील इज दिस कि जब से मैंने शुरू किया है, जैसे मैं सीजरियन के बाद डिलीवरी के बाद पेशेंट को 1.5 महीने बाद बुलाने लगी हूँ कॉन्ट्रासेप्शन के लिए, और सारा नहीं तो कम से कम 30% पेशेंट आने लगा है 1.5 महीने बाद कॉन्ट्रासेप्शन की एडवाइस के लिए। तो यदि हम लोग अपनी आदत में डालेंगे कि डीएनसी के बाद भी हमें काउंसिल करना है, एमटीपी के बाद भी काउंसिल करना है, और हम उसको कुछ ना कुछ देंगे तो पेशेंट विल बी रेडी, और इंजेक्शन के लिए तो तैयार आराम से हो जाता है पेशेंट, मुझे लगता है।
One more question is there for MS or MD candidate for doing MTP. Is MTP training is compulsory? No, it is not required for MD, MS or DHO. If you have done DHO or MD, MS or even 6 months size also is enough.
One more practical question. That they say that an adolescent can come with a partner or even a boyfriend. But do you think is it safe for us? Suppose a parent comes to know or there is some complication during anesthesia.
कोई पकड़ नहीं सकता।
अच्छा, नहीं पकड़ सकता।
कोई पकड़ नहीं सकता, क्यों? क्योंकि ये नहीं है कि वो आपको उठा के कुछ कर देगा, वो नहीं कर सकता, बिकॉज यू हैव द कंसेंट ऑफ द पेशेंट। आपके पास पेशेंट की कंसेंट है,
पेशेंट कंसेंट तो हमेशा ही
से बड़ा है। मतलब
लॉ का यही तो फायदा ना मैम, लॉ हमें प्रोटेक्ट करता है। लॉ का यही
हमें उसे यूज करना आना चाहिए लॉ को, और आप बेनिफिट
करना है कि सामने वाला कैसा है, असेसमेंट तो हमारा ही होता है पेशेंट के लिए।
हाँ हाँ,
असेसमेंट हमें दे, और आगे तो ये घटना इतनी बढ़नी है कि
बहुत बढ़नी है,
अल्टीमेटली करना ही होगा,
करना ही पड़ेगा। लिव इन रिलेशनशिप हैज बिकम वेरी कॉमन।
Now girls are coming after taking the empty pill themselves.
Yes, very common, very common.
Married girls are coming with they took themselves. Yes.
पूरी empty pill
फोटो ले लो, आप फोटो ले लो।
फोटो आधे लोग तो हैं, इसीलिए मैंने ले लिए 1-2। तो अभी फीडबैक फॉर्म सबको भरना है, उसके बाद ही सबको सर्टिफिकेट मिलेगा। तो सो प्लीज ऑल फिल द फीडबैक फॉर्म।
ओके, भर दिया।
Adolescents के both guardian consent is necessary or
मतलब
for adolescents abortion both guardians consent is compulsory or any one guardian?
Any guardian is required.
Not both guardians.
Yes.
बच्चा होने के चांस नहीं।
Any no question is there now. I think we should.
Yes.
Thank you सविता जी and आरती जी, प्लीज इसको दोबारा कराने के लिए।
Thank you everyone.
Thank you, Dr. Sangeeta, Dr. Anupam Yadav, for
Thank
coming
you, ma'am. Thank you, ma'am, for
arranging this. Yes.
Thank you so much, Rurki and Saranpur, for coming along with us. So it was possible for us to rearrange this meeting because we have done previously also, पर उन लोगों की 100 लोग allowed और हमारे 200 लोग थे, तो उन्होंने allow ही नहीं किया उनको। तो those who were left have joined today.
Thank you, ma'am, for inviting Saranpur Obs and Gynae Society.
to this very informative and wonderful webinar of
Thank you, Dr. Meenal. Thank you so much.
Thank you,
Dr.
ma'am.
Meenal.
Thank you so much.
You are from Roorkee, na?
No, I am president of Sarpur Obs and Gynae Society.
Oh, thank you so much. Thank you so much, Dr. Meenal.
Thank you, ma'am. Every speaker was excellent.
डॉक्टर मीनल,
All the
डॉक्टर
speakers were
अनुपम और एक थर्ड वन और होगा ना कोई?
डॉक्टर संगीता गर्ग, डॉक्टर
रुड़की ऑब्स एंड गायनी।
हाँ, वो मैंने देखना है।
Thank you, ma'am.
आ गया। Yes.
Aarti ma'am, you were so wonderful, so
Yes.
excellent, very excellent.
Both our
Explaining.
president and secretary were
All
very nice.
all speakers were excellent.
Thank you,
Thank you,
Dr.
ma'am.
Meenal. Thank you so
Thank you
much.
so much.
Dr.
Thank you.
Josna is also there, na, secretary. Yes.
Yes, yes. Josna.
Dr. Josna Agrawal.
सविता दीदी, अपॉर्चुनिटी का फायदा उठा लूं, वोट मांग लूं?
बिल्कुल मांगे।
रेडिकल डिसऑर्डर्स इन प्रेगनेंसी के लिए कृपया डॉक्टर अनीता रजौरिया को वोट दीजिए। आप अपने यूपी वालों को सपोर्ट करो प्लीज।
अब ये है ना, मीनल गोयल,
Thank you.
संगीता गर्ग, ये
बिल्कुल मैम।
जोत्ना अग्रवाल।
बहुत सारे लोग हैं, सारे प्रेसिडेंट्स एंड सेक्रेटरीज, प्लीज माय रिक्वेस्ट टू यू, हम्बल रिक्वेस्ट।
Sure.
थैंक यू सो मच।
फॉर्म मेल पे आया क्या?
ऑल द बेस्ट। क्या कौन सा
थैंक यू दीदी, थैंक यू।
फीडबैक यहीं पर है ना, भी चैट बॉक्स में ले लो,
Chat
फटाफट
box
फिर ये
में।
बंद होने वाला है।
Chat box में।
हाँ, रोल करो से
Okay,
ऊपर
ma'am.
इसमें है। आप सब अभी इसी को ले लो और इसको पूरा करके भेज देना, क्योंकि अभी ये
हाँ
बंद
जी।
होने वाला है।
ठीक।
चलो जी, बाय बाय।
Thank you.
Bye.
Bye bye.
Thank you, Aarti ji and Ruchika. Where is Ruchika? Is she left?
Thank you, ma'am.
Thank you so much. Thank you all.
Thank you, ma'am.
Thank you so much.
Bye. Hello. Hello. अरे चैट बॉक्स में ऊपर जाओ, मिल जाएगा चैट बॉक्स। हाँ, अरे नहीं, वो चैट बॉक्स में अभी हम वो कर रहे हैं ना, वेबिनार कर रहे हैं, उसके चैट बॉक्स में। अरे बीच में नीचे आ रहा है ना, पार्टिसिपेंट चैट बॉक्स में है। ऊपर कर, अरे चैट बॉक्स पे जाओ, चैट बॉक्स पे मिल गया।
Yes, ma'am.
हाँ,
Not able to submit this.
Hello.
Hello. Hello. Yes, sir. Tell me. Okay. What to do with the link? Sorry, I can't hear you properly. Can you call me after some time? See, already yesterday, a guy came and I have done my documentation and everything. He took my PAN card photo and everything. Huh? Yes, on the call it was happening. On call it was happening.
Kiriman, some members are not able to go for this chat box link. What can I do?
Madam, please copy that link, madam, and you share to the participant who have joined in the meeting, madam.
Okay.